Hi guys, we have to discuss today pulmonary compliance. When you hear word compliance, is mostly related to respiratory physiology section as have a high importance clinically. Also, it can be encountered in other systems that can distend and come back to the initial shape. By definition, the compliance of a system is defined as a change in volume that occurs per unit change in the pressure of the system. And when you want to know what is this compliance, it's easy. It's the ease with which the elastic structure stretches. It has synonyms like expansibility, distensibility. So it is how expand or distend any of the cavities mostly, or a cavity-like structure. Is basically a measurement of the elastic resistance of the system. And you see here formula like lung compliance is equal with change in lung volume per change in transpulmonary pressure. And this transpulmonary pressure is equal with difference between alveolar pressure and pleural pressure. Alveolar pressure is air pressure inside the alveoli, and pleural pressure is pressure of the fluid that is present between spaces or artificial space that does not exist normally and is filled with a very low amount of fluid, and it is placed between a visceral pleura, which is covering lungs, and parietal pleura, which lining chest wall layer. And normally the total lung compliance in an adult is about 200 milliliter per centimeter of water. But it is not about numbers. This lecture is about a general understanding and the meaning of the definition. So exist many types of compliance like static and dynamic. Let's talk about static compliance. It represents pulmonary compliance at a given fixed amount when there is no airflow and muscles are relaxed. So this equation is given for mostly for patient which is on a orotracheal intubation or any of the connection to the ventilatory machine, and muscle relaxants are applied, or neuromuscle blocking agents are applied. In this situation, a transpulmonary pressure equals the elastic and recoil pressure of the lungs and can be measured in the operating theater, of course, as muscles are paralyzed and there is no movement by itself. So there is applied a positive pressure to the pulmons. And here you see a formula like volume per plateau pressure minus PEEP. Of course, if PEEP is applied, for example, if we are giving 500 milliliters of air or of gases, and pressure will be like 17. So here we can calculate the static compliance at a given moment. So dynamic compliance is another type, and it is a continuous measurement of pulmonary compliance even during arrhythmic breathing or normal respiration of the patient, and at each point it is represented schematically and can change, of course, independence of pressure and volumes that are corresponding to that moment. It monitors both elastic and airway resistance, And airway resistance depends on air viscosity, density, length, and radius of the airways. Except for the radius of the airways, all other variables are relatively constant. Airway resistance can undergo physiological alteration by changes in the radius of the airway bronchus. There is bronchodilation or bronchoconstriction. Take a look at this diagram. So we have this diagram. Let me see. Okay, it's red. So it's a volume, like tidal volume and pressure, that occurs in dynamic compliance when we make a respiratory act, and this one is inspiration and that one is expiration, as you can see this clearly. So normally when we inflate lungs, we are producing dilation of the thoracic cage, and it produces intrapleural negative pressure, which pulls pulmon close and expand it. And this pressure is transmural, or calculated by intrapleural minus intraalveolar. And that one is expiration. This one is inspiration and expiration. And in the middle is placed a static pressure or a static compliance, mostly. For example, at this point, you see the corresponding pressure. When different readings of the lung volume are taken at specific measured pressure points and then plotted on a diagram, a pressure volume curve representing both elastic and airway resistance properties of the lung obtained. What is the importance of compliance? Lung compliance is inversely proportional to elastance. And this elastic resistance is both due to elastic property of the lung and or parenchyma and the surface elastic force. So compliance determines 65% of the work of breathing. And if the lung has low compliance, it requires more work for breathing muscles to inflate lungs. What are the factors that affect pulmonary compliance? As you know, elastic property of the lung tissue. This results from the collagen and elastin fibers meshed inside the lung parenchyma. When the lung is outside the body system and in a deflated state, it means that no one can affect inflation or expiration of deflation of the lungs. These fibers fully contracted due to elasticity. It's like a rubber, and this has this length, and after nobody is affecting or pulling in different direction, it tends to contract as a force of elasticity and tend to go to this side. So as a normal unit of elastins, or better called elastin fibers. When the lung expands, they elongate and exert even more elastic forces, similar to a rubber, as I told you, and thus the flexibility of these fibers determines the compliance of the lungs. Surface tension elastic force. The elastic property of the lung contributed by the surface tension of the alveolar lining. So normally, for example, if this one is alveoli, and air comes in two ways, like inside and outside. Normally, when it comes inside, it tends to go to the periphery and especially to the wall of the alveoli. And it exerts some pressure, and of course it will increase in volume. So compliance is a volume pressure depending changes, and of course the volume of the alveoli will increase, and this one is called elasticity, but the tendency of the same alveoli to come back to the previous shape is called recoil. Surfactant is if you measure the alveolar pressure using surface tension exerted by the lining fluid, you would apply Laplace law, where pressure is equal to 2 times surface tension on radius. One note that the pressure within the smaller alveolar will be higher than the pressure within a large alveoli, which will tend to collapse the small alveoli. However, in a typical scenario, this doesn't happen. For example, here we have one small alveoli, and close to this one we have a big one alveoli, and of course probability of this one to collapse is greater as lower radius, greater pressure. So lower radius, greater pressure, greater radius and lower pressure. Surfactant is a surface active agent in the fluid and secreted by type 2 alveoli, epithelial cells lining the alveoli. And it's a complex molecule containing phospholipids like dipalmitoyl phosphatidylcholine, and surfactant apoproteins and calcium ions. So as a combination of all this, they reduce the surface tension by partial dissolution. Lung volume. So compliance is related to the lung volume. Consider the formula related to volume and pressure. Once again, increased pressure decreased radius. Increased radius, decreased pressure, or something like that in correlation. And specific compliance is equal to compliance applied to functional residual capacity, or FRC. And finally, clinical significant, which is the most important part of any of the terms, as at the level of physiology is great to know, but you have to apply this on practice. Emphysema, or COPD, or chronic obstructive pulmonary disease. In both of these conditions, the elastic recoil property of the lung suffers damage due to genetic cause like alpha-1 antitrypsin deficiency. It is pathognomonic for emphysema, or any extrinsic factor like smoking for COPD. Because of poor elastic recoil, such patients have high lung compliance, and their alveolar sacs have a high residual volume, which in turn causes difficulty in exhaling the excess air out of the lung. So a trapping of the air inside the alveoli that do not participate in the breathing process and stays there. And patients develop, of course, shortness of breath. In pulmonary fibrosis, which is caused by certain environmental pollutants, chemicals, or infectious agents that could cause fibrosis of the lung tissue. In pulmonary fibrosis, lung elastin fibers are replaced by collagen. So no elastin by collagen, which are less elastic and decrease the compliance of the lung. Such patients need higher work of breathing to inflate more rigid lung alveoli. So any of the impediments that stay in way of passage of the air freely increase, of course, work of breath and need more energy to spend for inflate lungs. Newborn respiratory distress syndrome. Usually surfactant secretion begins between 6 and 7 months of gestation, and newborns that are delivered prematurely have little or no surfactant in the alveoli at all when they are born, and so their lungs have significant tendency to collapse. It is fatal and requires aggressive measures by continuous positive airway pressure, by CPAP mask, or even intubation and administration, of course, of corticosteroids at the corresponding doses. Atelectasis, or ARDS, acute respiratory distress syndrome. Atelectasis is a collapse of the lung alveoli and usually occurs in the dependent part of the lung, which is affected. Following operative anesthesia, this could be one of the potential complications. In cases of atelectasis, pulmonary compliance decreases due to a decrease in the volume of the lung and requires higher pressure to inflate the alveoli, or appliance of the PEEP, or positive end expiratory pressure. Thank you for watching this video, a short one, but hope this is useful for you, especially for clinical importance. Have a great time, guys.